In progress.
Join பண்ணியாச்சு. இவர்தானா? அப்படியா? செமையான வேலை கொடுத்துருக்காங்க போல. எப்படி? ஓ
Happy noon to all. I welcome you all on behalf of the Department of Microbiology, Mahatma Gandhi Medical College and Research Institute for the guest lecture on monkeypox by Dr. Surya Kumar, Associate Professor and Head Department of Microbiology, Government Medical College, Dindigul. Now I invite Dr. Praveen Charles, Professor of the Department of Microbiology, MGMCRI, to welcome and introduce the speaker.
Thank you, Dr. Vanity. I'm Dr. Praveen Charles, Professor, Department of Microbiology. Very good afternoon to one and all logged in here. I am much delighted to share my hearty welcome to encompass all of you gathered here in this pleasant occasion. I also welcome my fellow colleagues of the Department of Microbiology, MGMCRA, to join me welcome the gathering. At the outset, I would like to give my humble regards and appreciation to the Chancellor, Sri M.K. Rajagopalan, and Vice Chancellor, Professor Subhash Chandra Parija of our esteemed university, whose vision has made this occasion a reality. I am profoundly delighted and grateful to our beloved Dean, Professor Sitish Ghosh, who has given his consent for the event. I introduce and extend my gracious welcome to our renowned guest speaker of the day, Dr. J. Surya Kumar, Professor and Head, Associate Professor and Head, Department of Microbiology, Government Medical College, Dindigul. I take great pleasure to welcome the earnest target audience to whom the topic of the day, monkeypox, a re-emerging global threat, would expedite clinical and laboratory diagnostic knowledge in the present scenario. A small introduction of the resource person. Sir had, Dr. J. Surya Kumar had completed his undergraduate from Government Kilpak Medical College and his post-graduation from JIPMER Pondicherry. Sir has also done a fellowship in HIV medicine under University of Washington, Seattle. Currently, Sir is working as Associate Professor at Government Medical College, Dindigul. Sir is a national level master trainer for TB and HIV control program. And Sir has also established a state level Apex laboratory for diagnosis of MDR TB by Midget and Line Probe Assay and Gene Expert in collaboration with Find India. Some of the positions and honors held by Sir. Sir has been the former laboratory manager in GHTM Tambram, Chennai, India, a CDC Atlanta sponsored laboratory for TB HIV. Sir had been a convener for professional development certificate course in infectious disease and infection control. Sir had received COVID Warrior Award from Tamil Nadu Medical Council, Government of Tamil Nadu, Indian Medical Association, Madurai Medical College. And Sir has more than 20 articles in various journals and conferences. And Sir is serving as a reviewer of several journals and have been a member of the advisory board, organizing committee and technical support group of many national conferences, workshops and training programs. Having gone through the academic and research profile of our speaker, I am pretty much sure that we have here today the right person to address the spirited audience at the right moment. The next 45 minutes of the session will be adorned by our guest speaker, followed by question and answer session and vote of thanks. I request the participants to mute their mics for the next 45 minutes and to send their queries in the chat box to clarify their doubts with the resource person. And also we'll give a Google feedback form in the end. So those who are filling their feedback form, we would provide a certificate for participation. And over to you, sir. I welcome you once again. Now, sir, you can start sharing your presentation.
Thank you. Thanks for a wonderful introduction. I'm sharing my slide now. Visible?
Yes, sir.
Audible?
Yes, sir. Audible, sir.
Okay, I'll proceed. Good afternoon to one and all. So today I'm going to talk about, we are going to discuss about monkeypox, a re-emerging global threat. What is meant by re-emerging? Many UG candidates are there. You should know the terminology emerging and re-emerging. You are all aware of that. A new infection comes, it becomes a public health problem, then it is called emerging. But the same emerging, after some period, it decline, it become invisible. Again, it come back. Then it is called re-emerging global threat. So monkeypox, it was there, but after that, again, now it gain important because we have more number of cases. So with this small introduction, I'll go to the session. Yeah, this is blueprint. Today's session is very simple. Start with epidemiology, microbiology of that pathogen, and what it does, that's called clinical course, and how to diagnose, laboratory diagnosis, how to management and prevention. This is the aspect I'm going to discuss about monkeypox today. Any doubt anywhere, you can type in the chat box, because I keep one eye on the chat box of Zoom and another eye on the YouTube. So wherever possible, you can put your queries, I'll answer. So introduction, always we need to know about the pathogen. The first discovery at Denmark in Danish laboratory, 1958, by this person. He's a very famous person. Any guess? Any guess who is that person? Especially people who study about influenza virus, they know about the person. He make a concept. I'll tell the concept. Sometimes the hemoglobin titer will be high and the infectivity will be low. Usually the hemoglobin titer directly proportional to infectivity. But because of him, he found one concept and phenomenon. We call the name by his phenomenon. He is nothing but, his name is von Magnus, Prabant von Magnus. That phenomenon is called von Magnus phenomenon in influenza virus. So he is the person who discovered this virus. From where? Definitely people know, from some monkeys. Because of that, we call it as monkeypox. Yes, he found it from the experimental monkeys which are shipped from Singapore to Denmark. So it's first identified in the Danish laboratory from the monkeys. So we call it as monkeypox virus. Apart from that, the first human case, it was in 1958. After 12 years later, the first case was found in 9-year-old boy in Republic of Congo. After that, 50 cases were reported in Zaire belt. Then 400 human cases were reported in and around Equatorial Central and Western Africa. So only one line, that's all. It found to be endemic in Africa, that's all. It's mainly seen in African countries for a long time. 1958 onwards, 1970, they found the case. After that, almost 30 years, they found only in African area. Then the first case at 2003, the outbreak of monkeypox outside of Africa, they found in United Nations, United States. In May 2003, young child became ill with fever and rash after bitten by prairie dog. So they found where is the source, how the dog got. Then they found 71 cases that time, all were traced to Gambian pouched rats. So they found the reservoir is here, Gambian pouched rats. It is imported from Ghana and there is no mortality. That's a good news. It was on 2003. So first case was 1970. After 33 years later, they found outside of Africa. Then the story continues. 2017, Nigeria is the hotspot. Large outbreak, 500 cases were suspected, 200 are confirmed cases, and the case fatality ratios around 3%. Next, 2018. In September 2018, the first case of monkeypox found in UK. That also, the source is from Nigeria. A person contacted Nigeria before traveling to United Kingdom. After that, they found 3 more cases. That also from Nigeria. And one person is a medical worker. He did service in Nigeria. And 2019, they found first case at Singapore. See how slowly it's evolving. From 2017 onwards, it started its job. First case of monkeypox, a person traveled from Nigeria. So hotspot is Nigeria. 2021. Again, all people coming from Nigeria. So usually if you see where the cases are there, yes, usually see this image, beautifully they depict, all are African countries. It is locally acquired, see the color. And the purple color, it may be imported only few places, either United Kingdom, 1 or 2 cases from Israel, up to 2021, and some Singapore, few cases. And see here, this is the main belt hotspot of monkeypox. And now I start the story of outbreak, how it happens now. In 2022, the first case, we call it as index case, okay, from British, the person who traveled to Nigeria, again the Nigeria is the hotspot. The patient developed symptom of monkeypox on 29th of April, almost 4 months before. Still he is in Nigeria, he developed this in Nigeria itself. And 4th May, he back to UK, presented in the hospital. Later the same day, he was admitted, they suspected, and the case was confirmed. A serotype, a clade called West African clade. We have 2 types of, I'll tell in microbiological aspect. Okay, Congo Basin clade and West African clade, they belong to West African clade. On 6th May, the first case they confirmed. That is the index case. After that, 12th May, 2 cases, 17th May, 4 cases, 20th May, 11 cases in UK. Sir, is it necessary, these numbers? One interesting feature is there. After finding all that, it creates confusion among the people, especially public health people, because none of the cases were contact with Nigerian people. They never traveled to Nigeria. They never contact with anybody is having monkeypox. All different scenario, different age group, different people. How they got? Where is the source? Finally, that time they concluded, if the person developed the disease without known contact area, known endemic, not travel to known endemic area, then they call it as it's community transmission. A beautifully answered Dr. Priya and Dr. Shivani Nellur. Good, it's Van Wagner's phenomenon. Good. So they believe it's community transmission is started. That's called outbreak. Next is, see, just for the purpose, from May 18, within 10 days, they found Portugal, Spain, US, Canada, Sweden, Belgium, Italy, France, and 1 day later, May 19, May 20, Australia, Germany. That's all. Multiple countries. The outbreak started. Many number of cases also increased. See how many number of cases by till today, August 19, August 29th, total number of cases is 48,000 cases. 48,000 cases worldwide. Immediately people think, how many cases in India? Yes, we have 10 cases. India, we have 10 cases with 1 death at Kerala. But for us, we start the first day we found on July 14. July 24th, sorry. July 24th, we got the first case. July 24th is the first case. Till now, we have 10 cases were reported. This is Indian data. And I don't want to bore you. The journey started at 1958 to 1970, the first case. After that, traveling. Now, August 22. We are in August 22. A big story is that, don't worry. After that, the class became history class. So what the WHO did, on July 23rd, July 24th, we found the case 1 day before. Okay. The WHO declared monkeypox is a public health emergency of international concern because rising cases in different geographical area. And everybody got alert, including our government. Our government got alert the people at May itself. We developed the guideline for our country for May itself. I'm going to discuss about that guideline also. See, you should know your enemy. So the microbiology starts. Once you know your enemy only, you know how to tackle the enemy, or you know how to live with the enemy. So it is pox virus. You know, all know it belongs to Poxviridae, and it belongs to genus Orthopox virus. What are the characteristic feature? they have complete double-stranded DNA virus. Very important. I always used to tell. DNA viruses are too good than RNA viruses, because RNA viruses easily they undergo mutation, but usually DNA viruses are stable. Number two, RNA viruses, especially segmented RNA, they easily undergo genetic reassortment like influenza. They will act like a new virus. But here the possibilities are very less. So easily we can tackle the virus. It won't get mutated that much easily. And it is enveloped. What is the advantage of envelope? Everybody knows virus envelope is made up of lipid bilayer. So enveloped viruses are less resistant than non-enveloped viruses for disinfectants, especially lipid solvents like ether, acetone, alcohol, those kind of people. So we can easily kill the virus, just like COVID-19, that also enveloped virus. By using ordinary soap or hand sanitizer, alcohol, we can kill the virus. And it has complex symmetry, that is unique. Brick shape. Usually viruses, we have two types of symmetry, helical or icosahedral. Here it is complex brick shape virus. And one more interesting feature, the other brothers of this group, orthopox viruses, variola and vaccinia. These two are variola and vaccinia are nothing but smallpox. Very dangerous. Now it's not there. Cowpox virus. These are all other people belong to this group. Variola, vaccinia, cowpox viruses. See the image? So this image obtained from which microscope? It's a 2D image. You can see the internal structures. It is obtained from, yes, transmission electron microscope. And this is 3D image of the virus. We got it from scanning electron microscope. We call it as SM, scanning electron microscope. One is transmission, another one is scanning electron microscope. How colorful? That is artificial staining, because electron microscope real picture is black and white, like my background. So this is the real picture of same virus, black and white. Nobody likes. With the help of the software like Photoshop, you can give whatever color, pink, blue, rose, matching colors we can give. So 2D from transmission, 3D by scanning electron microscope. And already I told, this virus has two clades. This virus has two clades, two types, West African and Congo Basin. So what are the difference? You should know three difference. Very practical. First point people ask, sir, which is danger? Which is more severe? So please remember, Congo Basin is more severe than the West African. So what now we found the British person and the outbreak is maximum, it is caused by West African. So less severe variety only at present. Next question, what is the death rate, sir? Even though less severe, what is the death rate? So 3.6 is the case fatality rate for West African and Congo Basin is 10.6. Well, a little bit saved. And what about the transmissibility? How fast it can spread? Less in West African, more in Congo Basin. So the outbreak caused by the virus clade is a little safer at present because it's less severe, 3.6% only case fatality, and transmissibility also little less comparing with the other variety, Congo variety. Cameroon is the one country which has both. Otherwise, the West African clade and Congo Basin, they have different geographical distribution, but both are seen in one place is called Cameroon. Next is, what is the reservoir? It's a typical Viva question. What is the reservoir for monkeypox? Immediately people say monkey. Yes, right. Sometimes the gus will help. Yeah, because I told the very first, the isolated from the monkeys, they kept the name monkeypox. But don't it stop, think only monkey, other reservoirs also there. Non-human primates like Gambian poached rats, African squirrels, these are all other
rabbit, rat.
Okay, kindly mute. Admins, kindly mute others. Okay, cool. Okay, right. So how it got transmitted? Basically, it's a zoonotic disease. That means usually the real source is animal, first animal to human. If it's a pure zoonotic disease, we can control a little bit. Rabies is zoonotic disease, still we are suffering how to control. And a later stage, it becomes human to human transmission. That is danger. Any zoonotic disease, animal to human, you can prevent to a certain extent. Once it becomes human to human, prevention is very difficult. See here, the same thing happens. See the image. First, from the reservoir to human being. They contact with infected animals or contact with contaminated animal products, whatever way, close contact. And once the human got infected, then spread from human to human. That's called secondary infection. Contact with infected people or mother to child. Many modes of close contact. I'll tell you, respiration, inhalation, many are there. How the person got the infection from the animals? They got the infection, the primary, from the animals by bites of the animal, scratches or consumption of animal products. Once the human got the disease, human to human transmission through close contact with infected respiratory tract secretions or skin lesions, direct inoculation, inhalation, many are there. That's once you know the mode of transmission, you know how to control. Next is, what is the infected material? Respiratory droplets, large droplets, lesion material like a fluid, scab, those kind of materials, body fluids, and any contaminated material on surfaces of the contaminated materials with the virus, any material or surfaces. How the virus enters? The ideal source is respiration, respiratory tract, or local inoculation, mucous membranes of eyes, mouth, many things, broken skin via animal bites, many are there. Now the $1 million question. Monkeypox is a sexually transmitted infection or not? How many of you say yes? How many of you say no? I'm seeing the chat box. Monkeypox is a sexually transmitted infection or not? I can give some clue to you. I got an answer from yes. I gave a clue to you. Almost all of the case clusters include men, age 20 to 50, whom are gay, bisexual, and have MSM, men sex with men. Still, how many of you say yes? Many people say yes, 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 yes. But actually, monkeypox is not a designated sexually transmitted infection. Although monkeypox is not known to be sexually transmitted, sexual activity certainly constitute the close contact. Because it presents all body fluids, but it's not a designated sexually transmitted infection like HIV, hepatitis B. Yes, nicely mentioned, Dr. Indra. No, it spreads via semen, but not sexual. It's not a designated sexually transmitted infection, but spread is via sexual practice. Via sexual practices, the spread is there. Many people are there in this list. For example, Entamoeba histolytica, Giardia. They are all spread through sexual method, sexual practice, but they are not designated sexually transmitted infection. Trichomonas, it is a designated sexually transmitted parasite, like that. Okay, good. Next is the virus genetically mutated? I gave the answer long back. When I discuss about the structure of the virus itself, I gave the answer. It is a DNA virus. So less possibility for getting mutation. Okay, the answer is no. I gave the answer. I don't know how many people they know Tamil. If anybody knows Tamil, I can tell in Tamil. Nothing wrong in it. 2022 virus belong to the West African clade. Yeah, already 2018, 2019, what we got it from Nigeria, the same thing happened here itself. Because less possibility for mutation. Because of the reason easily we can make vaccine or treatment, anything we can easily make. If the virus have the property of keep on mutating, our vaccine may not work. Our treatment may not work. Okay, that's the concept. Next is coming to the clinical picture. Okay, we got the disease from the animal. What are the stages? There are 4 stages are there in clinical. Listen to me. Number 1 is incubation period. Any disease, we need to know the incubation period. Based on that, we can isolate or we can do contact tracing, many things we can do. So usually 5 to 21 days, but actually 6 to 13 days. But the range will be 5 to 21 days. So easy to remember, 1 to 2 weeks, but sometimes 1 to 3 weeks also there. So 1 to 2 weeks is common incubation period. In this incubation period, no symptoms, because that is called incubation period. Once the symptoms appears, the incubation period will be over. And in this period, at the end of the incubation period, you can see the virus in the blood. Virus present in the bloodstream at the end of the incubation period. So after contact, he may develop the disease by end of the first week or second week. Next is, what is the diagnostic clue? Very simple. Number one, recent travel to endemic area. Now we can't say endemic area because it's available in many countries. Number two, interaction with wild animals imported from the endemic area, or he may be a caregiver of the infected animal or human being. These are all the clues he may got exposed to the disease or to the pathogen. Next is, second stage is called febrile stage. It's 1 to 4 days. After incubation period, 1 to 4 days is the febrile stage. This stage, main thing is fever, headache, muscle aches will be there, and tiredness. These are all the common features of any viral disease. I used to tell you. This helping us to fill the page. But can you diagnose only with headache? It is small monkeypox virus? No. Even my class also causes headache to you. Okay. Muscle aches, fever, tiredness. These are all cardinal features. These are classical picture of any viral infection. Important one is lymphadenopathy. It's very, very important because lymphadenopathy not seen in the other differential diagnosis like smallpox as well as chickenpox. Smallpox, chickenpox, you won't get lymphadenopathy. But here the lymphadenopathy is there. That is the classical picture. So fever, headache, muscle ache, tiredness with lymphadenopathy. You can strongly suspect monkeypox. Apart from that, one more. In this age, in this time, we can see the virus in the blood. And you can get small lesions. We call it as enanthem in the mouth at the end of the first stage. Next stage, after 4 days, within 4 days after the lymphadenopathy, that is the classical, is rash stage. Any rash, you need to know about 3 points. Diagnosis. Number one, where the rash first appears. Number two, what is the nature of the rash? The description of the rash. Number three, how long the patient is infective based on the rash, infectivity period, how long he can transmit the infection to others based on the rash. These 3 points you should know about all rashes. For example, everybody aware of chickenpox, varicella. The same 3 points. It first appears on the trunk and moves to limbs. It is pleomorphic rash, different places, different type. And infectivity period 2 days before appearance of the rash to 4 days after appearance of the rash. Like that, for this, the rash first appears on the face and the trunk. Mainly face and trunk. Number two, the rash will be uniform. At one point of time, all will be macular or papular. That is called monomorphic rash. And the infectivity period, 2 days before appearance of the rash to still the appearance of scab, the person may be infective. Anyway, we are going to see. The first stage will be macule. I don't want to do surgical strike in dermatology. Second is papule. Third, you can get fluid, vesicle. Fourth, pustule. And final stage is scab or crust. Then it fall off with scar. That's it. So these are the different stages. But one point of time, one will be there. One point of time, all will be macule, or all will be papule, or all will be pustule, or all will be crust. At one point of, that's called monomorphic rash. Infectivity, 2 days before appearance of the rash to 5 days, appearance of scab. Scab may take 2 to 3 weeks. Because of the reason, the isolation needs at least 17 to 20 days we need to isolate the patient. because when the scab formation is complete, till the time the patient can be infected to others. And in the rash stage, it is monomorphic rash, already told. The virus may be in the blood early in this stage, and this stage we can get antibodies also. This stage, virus present in the skin lesions, you can take the scab or vesicular fluid, you can go for culture, or you can demonstrate the viral DNA in the vesicular fluid. Already told, antibodies produced in this stage. Stage 4 is recovery. Always we call it as convalescent phase or recovery phase. Patient has recovered. Specific antibodies are present in the blood, but ultimately no need to go for antibody. By seeing him itself, we can easily identify, because scars may be remain. For a long time, the scars will be present. So these are the 4 stages. I'll summarize. Just recollect, my dears. 5 to 21 days, it's incubation period, no symptom. 1 to 4 days, it's a febrile stage. Fever, lymphadenopathy, that's important. Headache, chills, many things. 2 to 4 weeks is rash stage, rash on the skin. Because of that, we need to isolate him for 3 weeks. It takes 3 weeks. And days to weeks is recovery. That time also no symptoms. These are the 4 stages of monkeypox. So if they ask monkeypox question, you need to write. Beautifully, you can put the graph, or how, whatever way you want to represent, you can represent. Always, you need to know the differential diagnosis. There's a huge list of differential diagnosis because it is having only rash. If you go to the dermatologist and say the rash, they will go 100 DD immediately, because that's a common. Smallpox, chickenpox, zoster, eczema herpeticum, syphilis, scabies, rickettsial scar, measles, other bacterial skin infection, even drug eruptions. Many are there, but I'm going to discuss only 2, smallpox and chickenpox. Okay. Smallpox means or monkeypox. With measles also I can take. See here. This is the symptoms usually. These are the 3: monkeypox, chickenpox, and measles. Fever in monkeypox, 1 to 2 days or 1 to 3 days before appearance of the rash, the fever will come. What about the nature of the rash? It is monomorphic and it is very slow. It's more dense on the face, I told, face, and it present on the palms and soles also. Lymphadenopathy, present maximum 10% death is there. This is about monkeypox. Chickenpox, 1 to 2 days before appearance of the rash, fever will be there. Lesions are multiple, pleomorphic, rapid development of rash. It is more dense on the trunk and moves to limbs. And lymphadenopathy absent, that is a point. Death is rare nowadays. Even if it is untreated, varicella pneumonia causes deaths, but it's very rare to see death due to chickenpox nowadays because we have beautiful treatment, isoclavir, many are there. Measles, 3 to 5 days before rash. Just a minute. Sorry. 3 to 5 days before rash. Lesions often multiple stages of development. It is also rapid. Starts on face, especially behind the ears, posterior auricular area. Lymphadenopathy may be present. Death, depending upon multifactorial. Measles rash, we call it as dripped paint bucket rash. If you pour the paint on somebody's face, it is very coarse in the face and very sparse in the body, like that. Okay, dripped paint bucket rash you can see in measles. Okay, we know the differential diagnosis also. So what are the complications of this infection? Mainly secondary bacterial infection, super added bacterial infection. Another thing, cosmetic problem, permanent skin scarring, or hypopigmentation or hyperpigmentation. These are all cosmetic issues. Even eyes, permanent corneal scarring, sometimes loss of vision. Pneumonia, dehydration, sepsis, and encephalitis causes death. These are all the differential diagnoses. You need to, complications due to pox virus. If it's untreated, then they may lead to multifactorial, depending upon the age, patient's immune status, many things are there. And what is the clade? Suppose in case of Congo Basin, all we can see. In case of West African, maybe less chance to get all those things. Next is coming to microbiology side is laboratory diagnosis. Yeah, this is based on WHO and Indian government guidelines. We have our own guidelines. Number one, any laboratory diagnosis, you need to know the sample. Here the samples are fluids from vesicle, blood, sputum, or scab, all sent to National Institute of Virology, Pune. All we need to send to National Institute of Virology, Pune. And please remember when to take sample. Government gave the clear-cut guidelines. See here, in case of asymptomatic, just you can wait, observe for the development of any signs and symptoms for 21 days of post-exposure. Suppose somebody came from endemic country, isolate him, don't take specimen, wait for 21 days. In case of any time the signs and symptoms are developed, then take specimen. If signs and symptoms develop, collect specimen as per the standard operating protocol. Suppose in case of symptomatic, rash face, the patient is having rash, that time you can take lesion roof or lesion fluid. You can take nasopharyngeal swab, oropharyngeal swab. You can take blood, urine, all specimens you can take. That is on rash phase because viremia will be there. Recovery phase, you can take the blood only for the purpose of antibody detection or urine. Got it? So if you want to take, you need to take multiple sites, number one. Number two, in case of rash phase, see the double star. You need to click the photograph and send the photograph along with the specimen. You need to photograph the rash and send the photograph, email the photograph along with the specimen. And this is the typical requisition form for monkeypox. It's available in the net. You download and keep it in your OPD. If you suspect anything, immediately you can fill fully. You need to fill every column. It gives full detail for the clinician and the country to tackle this threat. And other samples, you can go for fluid from vesicle and pustules, dry crust, biopsy maybe you can give. And you can take the lesion very vigorously to get adequate viral DNA. If the viral DNA is less, amplification may be less. Use viral transport medium. You are aware of that. Nowadays, viral transport medium, because of COVID-19, everybody aware of viral transport medium. Put the swab into the viral transport medium and send it to the laboratory. Okay. 2 lesions of the same type should be collected on one single tube. 2 vesicles mean takes 2 vesicles sample, put it in one tube, nothing wrong in it. And all specimen transported should be a technique called triple packing technique. Microbiologists, they know. Triple packing technique for transport of infectious specimens as per IATA norms. And what temperature? You can keep it in refrigerator, or by 1 week you can keep it -20. Long storage -80. That's a standard for many viral infection, many viral specimens. That's a standard protocol. Next is, what is the ultimate test? One and only test. Currently, what we are following, our WHO advised is RT-PCR, real-time PCR test. Everybody aware of the test because of COVID-19. Many centers we have, and now diagnosis of monkeypox not a big issue. If they give the probe and reagent, we can easily diagnose monkeypox. What is the algorithm? Any clinical specimen, first they do PCR for orthopox virus. Specific, genus specific. If it is negative, you can investigate for some other cause. It may be not due to pox virus. Suppose if it is positive, then you can do specific test for monkeypox. If it comes positive, report it positive, that's all. So first screening is for genus. If it is positive, it may be variola, vaccinia, smallpox or cowpox, anything. Then you go for specific monkeypox. If monkeypox is positive, then give positive. That's all. After that, we need genomic sequencing to know the clade and other thing and all. And one more point, always follow the government biomedical waste management guidelines, not only in the laboratory, in clinical also. And all waste should be autoclaved or disinfected before leaving the facility. Before leaving the facility, better you do autoclave and give, or chemical disinfectant you can give. Because what we should do, we need to pack in color-coded pins, we give to common treatment facilitator. That's good. But before that, extra protection we can do, we have autoclave. We can do autoclave and we can give it to them. If the autoclave is not available, that time we can give it to the common treatment facilitators. Apart from that, completion sake, electron microscope, we are not using for routine diagnosis. Only for textbook and research purpose, we are using electron microscope. Viral culture also, for making vaccines like research, we are using not for routine diagnosis. Antigen antibody detection, not much useful. It's not much useful because serological cross-reactivity will be there. We can't get diagnosis based on that. We can say that fellow got exposed, something we can tell. And treatment, my favorite slide. Yeah, that's all. Very simple. No proven safe treatment for monkeypox virus infection is there, but some drugs still, they are in use because something is better than nothing. We are using antipyretic, electrolytes, oxygen if needed, or empirical antibiotic therapy for bacteria to prevent secondary bacterial infection. This is supportive, but treatment there, they say ST246, tecovirimet, but not promising effect. In the 2018, the FDA approved. 2022 January, they approved for European countries this drug, but not much useful. They say it's safe with minor side effect in animals, but human study, we need more data. One more is also there. Cidofovir, the another version is called brincidofovir. That also not much useful for combating or treating monkeypox infection. Always prevention is better than cure. You know the source. It is from animal zoonotic disease. Avoid infected animal. Avoid contact with animals. Avoid contact with any infected materials like droplet or animal meat or whatever it may be. Third, isolation. That is very important. If the patient is infected, isolate him. You can spread what we can prevent the spread. And as usual, it is universal standard of precaution. Practice good hygiene and wear appropriate PPE. When you are carrying the patient, wear appropriate PPE. Good personal hygiene is needed. That's all. This is the way to prevent. And other way is, one is smallpox vaccine. It gives cross protection. And the drug, cidofovir, ST246, and immunoglobulin, vaccine immunoglobulin, already exposed to patient, used to control. It will not cure, at least it can control the monkeypox outbreak. And interestingly, we got a vaccine called Jynneos vaccine, FDA approved vaccine. This vaccine mechanism of action, it is close because monkeypox virus is closely related to smallpox virus. So the antibody produced against this virus will protect monkeypox virus. It's a smallpox vaccine, also protect people from getting monkeypox. See the protectivity, 85%. They did the study and they found 85% effective in preventing monkeypox. Got it? Another important way to prevent is ring vaccination. You are aware of that. In PSM, they used to teach ring vaccination. This is the person infected. The close contacts are vaccinated. And even you vaccinate close contact of close contacts. That's the ideal way to prevent. A person is infected, the surrounding area, what are the close contacts? That's called ring vaccination. Vaccinate everyone in this area. Ultimate question is, could it be a new pandemic? We need to answer like Nayak and Kamal Hassan, Theriliapa. No, not possible. Least possible. Because it's not like COVID-19. Easily spread through aerosol. It's a droplet is there. Number two, it's a DNA virus, no much mutation. Already we have what's called vaccines and many things. Even if it spread more means we can get more number of vaccines also we can get. And many of them, old kids like us, we already got smallpox vaccination, some cross protection will be there. So, but we can't underestimate. We can say this is a containable situation. We can't say it's a pandemic, but we can say it's a containable situation. It's a statement given by WHO chief. And what is our government guideline? Just 6 points they say. Number 1, high level suspicion. If anybody with unexplained fever rash, he recently traveled from a country which is endemic for, or which case reported in this country within 21 days, or contact with people or animal with monkeypox, suspect. Number 2, once suspected case need to be isolated, or proved case, whatever, either suspected or proved case need to be isolated in a designated healthcare facility. And all cases should be reported to district surveillance officer because it's one of the notifiable disease. And please follow all infection control practices. There is no shortcuts. Laboratory samples should be sent to National Institute of Virology, Pune, to confirm your suspicion. And very, very important and very difficult job for the public health people is contact tracing. Last 21 days, you remember. Last 21 days, wherever the person traveled, you need to go all the places, what are the close contacts, everything you need to trace the contact. If any case is reported in that particular area, like that. It's a difficult, tough, it's a Herculean task, but we need to do. To contain the disease, we need to do all these things. And this is a take-home message, my very favorite slide. Yeah. It is a re-emerging viral zoonotic disease. Yes. Suddenly we have some outbreak. 48,000 cases were there. So we should be a little cautious. Typically, it presents with fever, rash, and swollen lymph node, lymphadenopathy, and self-limiting. That is the point. Don't be panic. Usually it is self-limiting. So we need to know where there is a lymphadenopathy, skin rash, fever. Immediately we should suspect monkeypox. And symptoms usually lasting 2 to 4 weeks with the scarring and other complications. And transmission via close contact with infected person or animal material. Once you know this, you know how to prevent. Very important is isolation, contact tracing, and infection prevention and control. This is the need of the hour. If you do all these things, you can easily contain. You can easily contain the disease from your geographical area. And do not forget, it is a notifiable disease, and follow all the government guidelines. There is no shortcut. Don't follow any shortcuts, are easy, but follow all government guidelines 100%. So with this, now the time is exactly 3:03, 2:15, 2:18 we have started. 45 minutes. It's time to go for discussion. I'm waiting to take some of the questions. Hope you all enjoyed the session. You can unmute also, you can ask, or you can type.
Thank you, sir. It was very informative, thought-provoking lecture. I hope this lecture would have enlightened our minds on monkeypox. Now the session is open for discussion. Any queries, kindly please.
No questions? I got a nice feedback. Now itself they send the feedback. The chat box. Encouraging.
One question, sir.
Okay.
This outbreak is more prevalent among LGBTQ communities.
No, it's a coincidence actually. They mentioned it is not exactly the communities. They found it's a coincidence finding. It is not. They need to do more studies. But whatever data they have, it is there. But it's not exclusive for those community. But they say it's a coincidence at present.
Good evening, sir.
Yes, madam.
Sir, whether we are doing tests in King Institute now, or we are sending to Pune, sir, NIV Pune. Samples.
As per the government guidelines, till now they say send it to NIV Pune. But actually, public health laboratory, we send it to King Institute. From there, they are sending to NIV Pune. But we have wherever PCR, we have the facility to do this test. But till now, the ICMR guidelines as on date, NIV Pune is the apex center for testing.
Okay, sir. Sir, in case of PCR, doing PCR in our labs, Regarding the requirement, they are asking some tissue homogenizer, which we don't have. That is for samples.
Yes, madam. We need to purchase. You can purchase and we can do that.
That is for the pus sample, sir.
No, madam. Tissue sample also, if there's a homogeneous or no, it is helping in get more amount of DNA from the tissues. We can use biopsy specimen also. If you get the tissue homogenizer, you can get it, madam.
Is there a chance, sir, we'll get this soon? This kit, these kits, or
you pray if it become a great pandemic,
no.
then everybody will get. It's not like that. We'll get, madam. So soon, slowly we are improving because our country is developing country. So slowly we'll get. See, 2 years before, only 3 to 4 government laboratories are having PCR facility. Now you think all district headquarters hospitals, everybody is having PCR facility. So like that, one point of time, we may get everything. We'll need to wait for that. That's all.
Thank you, sir.
So one more question is there. What is the survival time of virus in droplets and body fluids?
Now, actually, they say it is 1 week. 1 week in the presence of moisture. That's a monkeypox virus survival. Not only monkeypox, smallpox also they say thing, but it's an enveloped virus, so easily they will get it dried. Once the fluid got dried, then the DNA got disintegrated, we lose the virus. So approximately 1 week, they say few days to 1 week is the time it survive in the body fluid and other thing and all. Okay. And I got a question, what specific kit for monkeypox? CDC recommended 2 to 3 kits actually. By NAV Pune, I don't know what they are doing actually. I'll get back to you with this specific kit. Because once they're distributing the kit only, they'll say, use this kit. I don't know what they're using in NAV. I'll get back to you, but the CDC recommended 2 to 3 kits. And WHO also.
Any other questions? So during sample collection, whether we need to follow all the personal protective equipment?
Yes, sir. Yes, sir. There is a 23-page guideline is there for government guideline is there. And what kind of PP you should use to collect different kind of samples, because COVID means we are taking only nasopharyngeal. Here you need to take vesical fluid as well as scab, as well as nasopharyngeal, oropharyngeal swab, even blood. So many specimens we need to take. So each specimen, how to take a standard SOP is available in ICMR website. We need to follow that.
Yes, sir. And PCR, whether 2 different type of one orthopox specific?
Yes, sir. At present they are using one is orthopox genus specific. Once it positive, then they can find because maybe costly and non-availability or some other reason they're using specific. When we started with COVID work also, first we do one for E gene. When the E gene is positive, then we'll go for N gene or ORF. Like that we did. Now everything available in one PCR. So soon we may get only single test. It will say it is monkeypox or not. But now we are doing 2 steps as per ICMR NAV Pune. They are doing 2 tests. One is for orthopox. Once it's positive, then they go for individual monkeypox DNA.
Thank you, sir. Any other questions? Kindly fill the feedback. Has been already put up in the.
Yeah, there is the feedback form is there in the chat box. You can feel free to fill the chat box. And if there is no more questions, I'll wind the session with thanking the organizers to give the opportunity. It's a very good session. I enjoyed a lot. Thank you very much.
Sir, just a minute, sir.
Yeah, please.
We have a vote of thanks will be given.
Yeah, please.
So you can just stop sharing.
Happy noon to all. Gives me an immense pleasure to deliver the vote of thanks for this event on behalf of the Department of Microbiology, NGM-CRI. First of all, I would like to thank our chief guest, Dr. Surya Kumar sir, who honored this event with his informative lecture. I would also like to thank all students, staff, resident doctors, all faculty members of MGMCRI, and all the other external participants. Thank you one and all. Have a happy day.
So thank you very much, sir.
Thank you.
It was very informative, and even ordinary, those who don't know microbiology, they will understand.
Thank you, Ma. Thanks for the feedback. Thank you. So I'm leaving now.
Yes, sir, we'll end the session. Close one,